We're very pleased to have Dr. Sarah Cox here, President of the Association for Palliative Medicine, who's going to introduce the report, if you like, and from that point of why it was important. And then we'll hand over to Dr. Mark Juniper and Dr. Alex Goodwin, who are two of the report authors, to present the main findings. So, Sarah, I'm going to pass over to you. Okay.
Marissa, thank you. I'm delighted to have been invited to introduce this fantastic report. I'm a consultant in palliative medicine. I'm current president of the Association of Palliative Medicine, and I was also on the study advisory group, annoying the authors enormously with my level of expectation about what they were going to come out with, but they did a good job managing us all. So just to put all this in context, a lot of this will be known to many of you. We know that most of us are going to die from long-term conditions with a predictable end-of-life care phase, where good can be done. We know now that dementia is now the leading cause of death. We know that people with non-cancer diagnoses have as much need for good end-of-life care as cancer diagnoses, but are less likely to receive excellent or outstanding care at the end of life. In terms of where we die, this is data from the government from 22, where 43% of people died in hospital, 28% at home, and 20% in care homes. A minority, obviously, of us will get the opportunity to die in hospice. But the scary thing that we've known for some time from Simon Etkin and colleagues' work is that the number of deaths are rapidly increasing. The complexity of what we die with is increasing. So this year, I think the current number of deaths in the UK is about 670,000. By 2035, there's going to be an additional 135,000 deaths. So whatever we're doing currently now, we need to prepare for there to be a lot more of it. What about end-of-life care in hospitals, which is the focus of this work? About 70% of people that died in 22 spent time in hospital in the last 6 months. Some of that will be avoidable. It contributed to a total of 8.4 million bed days. And we have quite good information about the last hours and days in hospital from the National Audit of Care at the End of Life, or NACEL, which some of you will be very familiar with being involved in or looking at the reports of. What we have less awareness of is the bit before, and that's where this study comes in. And why is that period of time important? Because if we identify that the patient may be in the last bit of life, in the last 6 months or so of life, if we then discuss that with them and their family, it enables them to make those really important informed choices, not just about healthcare and where they want to be and what they want to have, but also about all the other stuff, you know, our bucket list that we may want to engage with in the last bit of our lives. And it helps to guide us as professionals to focus on what's really important for them. So hopefully what I've phrased is why this report is so really very important. And I'm going to hand over now to the report authors to tell you what they found.
Yeah, thank you, Sarah, and actually particular thanks to you for the amazingly helpful input you provided to us to make sure that we came up with the right recommendations and worded the report in a way that was appropriate for those who really understand palliative care. So my first slide actually summarises a lot of what Sarah's just said, and I'm not going to repeat this, but Sarah's just outlined the scale of this problem, why we ended up doing this study. And she's described the fact that these long-term conditions often have a predictable course. Put the graphic in the corner of the slide here, outlining the cancer, the organ failure, and the frailty trajectories, just to show something of that predictability. The thing that often makes us want to do studies with NCEPOD is where we see variation in the system. And we know that there's a lot of variation around end of life and palliative care, that death in hospital, which is pretty common, and yet people would say they would prefer to die at home. Death in hospital varies by underlying condition, and then palliative care provision varies by where you are in the country, by which day of the week you happen to be, either in hospital or at home, and varies based on your underlying condition in terms of whether you're more likely to receive palliative care, which is generally given more frequently to people with a cancer diagnosis than with other diagnoses. And yet we know from population data, as it says here, that there is a huge need for palliative care provision, and there is an underprovision. And so that was why we ended up wanting to do this study. So the study itself, those of you that I hope have read it in the last month since it was published will know that we looked at adults who died in hospital over a 6-month period in 2022. We chose primary diagnoses or primary conditions as the cause of death to show us the various disease trajectories. Dementia as an example of frailty, heart failure as an example of organ failure, and lung cancer, those with malignancy. We actually added liver disease on the advice of the study advisory group, because this is a condition which occurs as a long-term disease, but it occurs in younger people, and we thought there may be material differences in that group. We also took a sample of people who died in the community by identifying their hospital admission and then knowing that they died within 6 months of that admission. And just again to show you the scale of this problem with these 4 diagnoses, there were 16,500 deaths in that 6-month period in hospitals, or 16,500 patients identified. More than half of those patients died in hospital. And actually a similar percentage, 56%, also had previous admission to hospital within the 6-month period that we studied. And actually 80% or more of them had some form of hospital contact if you added emergency department attendances and outpatient hospital visits. So this was a study looking at the opportunities that we might have during that prior period. The data that we got, we have data sources from a clinician questionnaire whether the consultant looking after the patient at the time of that final admission gave us information about both that admission and the previous 6 months. And then in the NCEPOD office in London, we had half of that number of patients had their case notes reviewed in depth, in detail, by peer reviewers to give us advice on whether they thought there were things that could have been improved. In order to be efficient in our use of data, we had an arrangement put in place by HQIP that the NACEL data from organisations around the country was available to us. When we present the data, the denominator that we present will often vary from the 701 and 350 that you see on the screen here, because when we look at data, we look at the number of questions that were answered in order to describe it. So what were the high-level recommendations that we made? And I've certainly learnt about this. I found as a report author, actually, I found myself writing the words end-of-life care when what I meant was palliative care. And I think we all have come to think of end-of-life care as the predominant thing delivered by palliative care teams. And I say this as a general physician rather than as a specialist in palliative care. And I think there's an important message here that we need to get across to those of us that are not do not have our primary interest in palliative care, palliative medicine. What we found was that in 2/3 of patients, their recovery was thought to be uncertain. So we have to learn how to deal with uncertainty. And when we were first presenting the results of this study to the advisory group and the reviewers, we presented this data on parallel planning, where we found that this had been used in almost 1/3 of patients. And I thought, oh, that's a really good thing. Actually, what I learned was this is not a very good thing, because we need to do this more frequently. We need to set a culture where actually what we do in those months before people die is we think about delivering palliative care alongside the care of whatever organ-specific disease that they have. And what we found was that if you did have parallel planning, you were more likely to get specialist palliative care input at the time that you were in the last days and weeks of your life. I don't think you can talk about a report to do with palliative care without talking about resources. And the organisational data that we had shared from NACEL showed us that in 3 out of 5 hospitals, you were able to get 7-day access to palliative care. Flip side of that, in 2 out of 5, you can't. But of course, this data shows that it is possible to provide 7-day services, one of the standards that we aspire to. And from the case note review and the clinician data, what we found was that there were opportunities during those prior 6 months to improve palliative care in almost a third of patients. And in 1 in 6 of these patients, it was considered that this was specifically around specialist palliative care involvement in that patient's journey. And how can we provide more palliative care and do more parallel planning without talking about this? So another recommendation we came up with was to try and normalise these conversations about death and dying. Despite the fact that recovery was uncertain during 2/3 of these admissions, almost all of the deaths were thought to be unsurprising by the case note reviewers. And yet, despite that, in almost 3/4, patients didn't have their preferences for care at the end of life discussed with them, or there was no documentation of this. So we came up with this recommendation about normalising conversations and suggested tools such as the surprise question. Would you be surprised if this patient died within the next 12 months? To prompt thought about whether we should use the concept of palliative care alongside their organ-specific care. And we also suggested that a prompt might be recurrent hospital admissions in people with advanced chronic diseases, that this might prompt us into having these conversations and maybe then producing an advanced care plan. So I'm going to hand over to Alex now to talk about a couple more of the recommendations.
Thank you, Mark. One of the things we asked about was whether there was a named care coordinator for patients on the pathways with the diseases that we selected. And there was documentation of a lead person in about 65% of patients. And when there was a lead person documented, this led to better care, but also when it wasn't documented, the care was not quite so good. Our 5th recommendation is that palliative and end-of-life care should be a core competency. And I have a personal view of this, in that it took me 10 years as an intensive care consultant to have the realization that as doctors, we have as much duty to managing patients who have terminal illness and at the end of their life as we do to saving them. And I look back at my own training and realized that I had very little training in managing that phase in patients' illnesses. So we looked at how much training in end-of-life care was included, particularly in induction programs, which we all have to undergo when we join new organizations. And it was only in 65% of hospitals that this occurred, and that it was in mandatory or priority training in only half the hospitals. Now, we're all required for our appraisal to undertake mandatory training. And so we feel this is an area where better training will allow clinicians and members of staff who are patient-facing to help recognise and deliver a better standard of care to patients nearing the end of their life or with terminal illness. we asked our reviewers to grade the care in a qualitative manner. And when they, at the end of the patient review process, we found that good practice occurred in 36.7%, room for improvement in the clinical care in 31%, room for improvement on an organisational basis in 7.6%, and room for both in clinical and organisational care in about 20%, and that there was less than satisfactory care in just under 5%. But what we did find was that when there was a parallel planning approach, the rate of good practice was higher, and also when a specialist palliative care team was involved, that too led to better standards of practice. We allowed the clinicians in their review to make comment. And here are 3 comments. The first one, advanced future care planning is not taking place on a big enough scale for people with advanced frailty in the community. It's also not being addressed effectively in hospitals. So, for example, prior to discharge from hospital, this process takes significant time for sensitive discussion, and healthcare professional resource makes this a huge challenge. So that was the recognition that we found in the report from the clinicians managing these patients, that there is certainly room for improvement.
And I'm going to speak to the top right of this slide, which shows, I think, a situation which we would all find fairly familiar. People with a terminal disease admitted to hospital, dying fairly soon after that admission, and where there could have been better links with the community. Again, hopefully, the recommendations that we make help to solve some of these issues that were raised by the clinicians who gave this feedback.
And then the final bottom right, this is the theme coming through. We need better access to palliative care services for our patients. The current service is under-resourced. Many patients often wait and they don't get the care they deserve. And particularly discharging patients to the community, a fast-track discharge isn't really a fast track. It doesn't occur within 24 hours, more like 3 days. And we need the funding to be organised once they're discharged, not having to have it approved beforehand. So these were the clinicians who were looking after the patients, and their comments mirror our recommendations. So what we can do for you, online, the report is available. There will be a QR code as well for you to be able to download it. There's the full report, a summary report, an infographic for you to print and perhaps display in your organisations, a recommendation checklist which allows you to look at the action you might require, set a timescale, set responsibilities, an audit tool, a driver diagram so you can visually display your theory of what can or might drive change within the organisation, a fishbone diagram which we've populated. Some of you will know these as Ishikawa diagrams, so you can look at cause and effect of why your organisation isn't particularly achieving what we suggest you might like to. And also, I think, a very good précis, a commissioner's guide. So you can send this to people who are responsible for the service, because it sets out what it should look like and why it should look like that. And of course, the recommendations are interwoven into it from this report. Sarah, I don't know if there's anything you wish to comment on or add or ask us to elaborate on before we open up to the floor.
Thanks very much, both of you. I think from all of us on this call, I think we should say a very big thank you to NCEPOD and the team and all of you for what's been an incredible piece of work, and come out of it with a report with some really practical, sensible recommendations.